But I am Karl Lewis, a medical oncologist at the University of Colorado, specializing in the treatment of melanoma and other skin cancers, and this is an update on skin cancers. And the clock's not running here, just to let you know. But melanoma continues to be a major global cancer burden. And the highest incidence and mortality of melanoma is really concentrated in North America, Western Europe, Australia, New Zealand area. And these tend to be areas of kind of Caucasian population, higher UV radiation exposure. And for 2020, it's estimated 325,000 new cases of melanoma arose with around 57,000 deaths. And if the current trend continues, by 2040, the estimates are over 500,000 new cases of melanoma with about 96,000 deaths. And really, melanoma, as you all know, is a cancer of the pigment cells of our body, the so-called melanocytes. And the role of the melanocyte is to make melanin, which gives us the pigmentation of our skin. And our skin color is based on the ratio of what's called eumelanin to pheomelanin. And it's polymorphisms in the melanocortin-1 receptor gene that are associated with differences in the type of melanin that our body produces. And so eumelanin, which is darkly pigmented, very photoprotective, is produced when melanocytes are stimulated through the melanocortin-1 receptor signaling pathway. And pheomelanin, which is more lightly colored, kind of a reddish tint, is made when melanocortin-1 receptor is inactivated. And it's these ratios that give us our skin phenotype, our ratio. So these, I'm about called them patients, they're not patients. These people here in this picture all have the same number of melanocytes. They all produce melanin. It's just the ratio of pheomelanin to eumelanin that gives us our skin type. And the patients, the people on my left-hand side with the light skin are more pheomelanin producing, and it's not very photoprotective, and they're very susceptible to UV damage and subsequent skin cancers. The people on the right, more eumelanin production, photoprotective type of melanin, and less likely to develop DNA damage from UV radiation. And it's that UV radiation and DNA damage that really leads to cutaneous malignancies. And this is a study that was published in 2019. It just took various tumor types and looked at relative tumor mutation burden. And these are tumors with greater than 10 mutations per megabase. And on the right-hand side of the graph here, which is the tumors with the most mutations per megabase, were all cutaneous malignancies. So basal cell carcinoma of the skin, cutaneous squamous cell, cutaneous melanoma. So they're all heavily mutated tumors. And when you talk about treatment options for cancer, really the way I talk about it with patients is we really have three general ways to treat cancer. We have surgery, you cut it out. We have radiation, you shoot x-rays at it. And we have systemic therapies, chemotherapy, hormonal therapy, immunotherapy, targeted therapy. And for melanoma, really where our focus is on immunotherapy and targeted therapy. And it may be that these cancers are so heavily mutated that it lends itself to having targets to go after. It lends itself to having these tumors be susceptible to immune surveillance. And so what are the targets that we have in melanoma? Well, one of the common pathways that's mutated in melanoma is a so-called RAS-RAF pathway or MAP kinase pathway. And it's a series of proteins, and this is certainly a simplified version of this pathway, but an intracellular protein, RAS, stimulates an intracellular protein called RAF, which stimulates MEK, which phosphorylates ERK, and then that leads to other transcription proteins being activated, and it leads to cell division, gene transcription. And in melanoma, about 20% of melanomas harbor mutations in NRAS. And about 50%, upwards of 50%, harbor mutations in an isoform of RAF called BRAF. And it's really this BRAF mutation that can drive the growth of some of these melanomas, and we have the ability to target. And I feel bad there's so many vendors here. This is just an old report we have. You can send tumor off and look for these mutations. It's not something that people are born with. It's something that the tumor develops. And you can send off and look for mutations. And this patient had a mutation in BRAF. specifically a V600K mutation. And that's what we have the ability to target, that specific BRAF V600 mutation. And so this patient would be a candidate for targeted therapy. And it was this study that was published actually 12 years ago now that really is going to change the treatment paradigm for melanoma. And this was a phase 1 study that was published in the New England Journal of Medicine, and it looked at inhibition of mutated activated BRAF in metastatic melanoma. And the responses that we're seeing were quite dramatic, so like things we had never seen in melanoma up to that time. So it was very, very exciting. This is a PET scan of a patient down at the bottom of this at their baseline, and you can see, for those familiar with PET scans, this patient had widespread metastatic cancer, and by day 15, nearly complete resolution of all the metastatic cancer. So these responses were very rapid and deep responses. And at the top of the screen is paired biopsies. So the top panel is baseline, and here is phospho-ERK, for example, which is stimulated by mutated BRAF down that protein pathway. And you can see by day 15 biopsy, the phosphorylated ERK is essentially gone. And then some cell cycle markers like cyclin D1 and Ki67, marked reduction in that as well. So these responses were quick and durable, and it wasn't just this one patient, it was most of the patients treated on study. And this is what we call a waterfall plot, where each of those bars represents a single patient. 0 is the patient's baseline tumor burden, and anything below that, their cancer is getting smaller. Anything above that, their cancer is growing. And you can see that almost all of the patients treated on this phase 1 study with this targeted therapy had decrease in their tumor burden. There was one patient that had primary progression as their response, but the majority benefited. And this is an example of a patient treated early on with a BRAF inhibitor. You can see in panel A, this patient had widespread subcutaneous metastasis, treated with the BRAF inhibitor, and essential resolution of all of those tumors. And he's gained weight, he looks more healthy. But the problem is panel C, that resistance develops. And eventually the cancer starts to grow in most people despite hitting that target. It was pretty early on recognized that most of the resistance was reactivation of that MAP kinase pathway. And so really what was done is now the standard of care is dual blockade of that pathway, both blocking the mutated BRAF as well as MEK. So patients get BRAF and MEK inhibitor combinations as the standard. And there were multiple studies done that looked at BRAF MEK combinations compared to BRAF inhibitors only, showed that the combination was better than the single agent. And this is one of those studies, the so-called COMBI-V, where the combination of dabrafenib and trametinib, BRAF and MEK, compared to vemurafenib, a single-agent BRAF inhibitor, showed improvement in progression-free survival. But there was problems with this. When these studies were published, the median progression-free survival, even for the combination arm, was still only about a year, and that half of the patients would ultimately develop disease progression within a year. And the follow-up of these studies was short, so we really didn't know what was going to happen long-term. We do now have some long-term data that shows that there is a subset of patients that we can treat long-term, and they maintain their control of their disease without developing resistance. But still, median progression-free survival was only about 12 months. And so really where the other breakthrough came was with immunotherapy. And we've known for a long time that melanoma can stimulate the immune system. We used to treat melanoma back in the old days with an immune cytokine called interleukin-2 that led to complete responses in about 5% of patients. And then we saw situations like this. So this is a patient who came into our clinic. She had this long-standing primary melanoma growing on her abdomen. She actually had metastatic disease to her lymph nodes. You can see that there's a biopsy site in kind of the non-pigmented area there, and it essentially showed complete regression of the melanoma in that area. So obviously there was tumor there, but the immune system was recognizing it, made that regress. But some of that still developed, still metastasized. This is a patient who was referred to our clinic after showing up to his primary doctor with complaints of loss of skin pigmentation, and he had fairly widespread vitiligo, and it subsequently was found he had metastatic melanoma. And this was an immunologic response to his metastatic melanoma. So we know that the immune system can get stimulated. We just needed to be able to take advantage of that. And I'm sure you're all very, very familiar, and you've heard this morning and this afternoon about checkpoint blockades, and these really kind of change the standard for melanoma. And there's two checkpoint blockades that we commonly use in melanoma, PD-1 blockers and CTLA-4 blockers. And this is an old cartoon published by Tony Rebus in an editorial in the New England Journal of Medicine, but I still like to go back to this. And this is the way I talk to patients about the way these therapies work. And essentially at the top of this diagram, there's the priming phase of the immune response, where a dendritic cell, an antigen-presenting cell, will present antigen in the context of MHC to a T cell. That T cell will then go out to the peripheral tissue, recognize cells expressing that antigen, in this case tumor antigen, and then kill those cells. But if you look closer, and I don't have a pointer, I apologize, but in that box, there's some other interactions that happen that are very, very important. So on that antigen-presenting cell and on that T cell, you need co-stimulation. And B7 on the antigen-presenting cell binds to CD28, and that's vital for co-stimulation. That T cell is then activated. But then CTLA-4 starts to be produced by those T cells. And CTLA-4 will bind to B7 with much greater affinity than CD28. And even though it's recognizing that antigen, that T cell is not stimulated. And we have blocking antibodies against CTLA-4, which is ipilimumab. And then when the T cell gets to the cancer cell, even though it's recognizing that antigen, if it's expressing PD-1 and the tumor cells are expressing PD-L1, when PD-1 and PD-L1 interact, that T cell is turned off. And so they're blocking antibodies against PD-1 and against PD-L1. And it was this study that really set the standard of care for melanoma for kind of the years to come. And it was a combination of nivolumab, a PD-1 antibody, combined with ipilimumab, an anti-CTLA-4 antibody, compared to either nivolumab alone or ipilimumab alone. And this has been updated multiple times. It's been updated since this, but this is the 5-year update of this so-called CheckMate 067 study, and you'll often hear that, CheckMate 067. And here's the long-term survival curve. So the patients treated with nivolumab and ipilimumab at the 60-month mark, 5 years, 52% of those patients remained alive. In the nivolumab arm, 44% remained alive, and in the ipilimumab-only arm, it was about 26% of the patients. Now, what's important about this study, important to remember, is that it was not powered to compare the combination of ipi-nivo to nivo alone. The comparator arms are ipi-nivo compared to ipilimumab alone and nivolumab compared to ipilimumab alone. So we don't know from a statistical standpoint that the ipi-nivo combination is actually better than single-agent PD-1, although we all believe it, and these are the curves as they are. So really, ipi-nivo became the standard of care for patients who presented with metastatic melanoma, but that came at a cost, and that cost is toxicity. And when we give the combination checkpoint inhibitors, a significant proportion of those patients will develop what we consider severe immune toxicity, which is grade 3 or 4 in these clinical trials. And it's close to 60% of patients will develop grade 3, 4 toxicity. And about a third of the patients actually have to stop due to a treatment-related toxicity. So people have to be fit enough to tolerate a therapy like this. It really isn't for everybody. But fortunately, most of the adverse events were managed, resolved within a short time. And importantly, those patients could still do well. Even though they had an autoimmune toxicity, had to come off therapy, couldn't continue, it didn't mean they didn't derive benefit from the treatment. And this is looking at patients in that CheckMate 067 study who discontinued treatment because of a treatment-related adverse event. So they came off of therapy. And you can see at the 5-year mark, half of those patients were alive. So even though they had the toxicity, they could still derive benefit, and that benefit could be long-lasting. And I like this pie chart because it really kind of sums that up. And this is just looking at patients alive at 5 years on those 3 arms of that CheckMate 067 study. And so the pie chart on the top left there is those who received the combination PD-1 CTLA-4. And the blue is they're still on the trial therapy, and only 8% of the patients in that group remained on the trial therapy. About 20% of those patients, 18%, went on to receive some subsequent therapy. But 3/4 of those patients, almost 75%, required no further treatment. So they were alive at 5 years and had never received a subsequent therapy. And you can compare that to the nivolumab group alone, where 58% didn't require subsequent therapy, but more than half of the patients in the ipilimumab group went on to a subsequent therapy. So This regimen can be toxic. Patients often have to come off, but it doesn't mean they derive benefit. And they're often deriving that benefit, not requiring to go into the doctor's office every 3 weeks or 4 weeks for infusions. They can come in on a more reasonable schedule. So the question is, well, what do? We have these great targeted therapies that can lead to very rapid and deep responses, and we have immunotherapy. Which one's better? When a patient comes through the door, they have a BRAF mutation. What should we give them, the targeted therapy or the immunotherapy? And the answer was we really didn't know. Our bias tended to be towards immunotherapy because of that chance of durability, because of the concern of progression, but we really didn't know what the answer was. And there was a study that was presented late last year where we finally have data that helps guide us in that situation. And kudos to Mike Atkins and the investigators here, because this was a very difficult study to do. It's called the DREAMseq trial, where they took patients with BRAF mutated melanoma and then randomized them to either immunotherapy up front with Ipi/Nivo or BRAF/MEK. And this was hard to do, as I said, because we all had our biases. We didn't want to just randomly put somebody on a BRAF or randomly on immunotherapy. We had our biases. And we know from the CheckMate 067 study that BRAF mutated patients can respond to immunotherapy. So it's not like they had to receive a BRAF inhibitor. And so this was the study. BRAF mutated melanoma patients randomly assigned to either Ipi/Nivo up front, and if they progressed, they then went on to dabrafenib, trametinib targeted therapy, or they received targeted therapy up front, and if they progressed, they went on to Ipi/Nivo. And here are some of the results. In terms of duration of response, those who were assigned to the Ipi/Nivo arm did much better than those who were assigned to the dabrafenib, trametinib arm, the targeted therapy. And the median duration of response for the targeted therapy was about 12.7 months. And that's not surprising. It's about what we had seen in the other studies. And the median duration of response was not reached for those who received the immunotherapy. And if you look at progression-free survival, you saw a marked improvement. Progression-free survival for those who were assigned to immunotherapy over targeted therapy. And if you look at the 2-year progression-free survival, those who received Ipi/Nivo, 42% remain progression-free. 20% or thereabouts who received the targeted therapy. So these are what we had seen in the studies as well. So it kind of panned out that, those who get immunotherapy can, if they respond, it can be durable. But what's interesting, again, I don't have a pointer. If you look at the early curves there, it's the opposite. In terms of progression-free survival, there's less progression if you receive BRAF/MEK up front than immunotherapy. But then at about 10 months or so, a little bit before, those curves start to cross. So patients will progress early on immunotherapy, do a little bit better on targeted therapy, but at some point those curves cross, and long-term patients on immunotherapy can do better. And that's also shown in overall survival. So here's the overall survival curves, and for Ipi/Nivo, it's 2-year overall survival rate of about 72%. Versus 2-year overall survival rate of about 52% for those who receive the targeted therapy. And that's an absolute difference of about 20%. So this really sets the standard of immunotherapy as the preferred frontline treatment for patients who present with metastatic melanoma, even if they have a BRAF mutation. But again, if you look at the early part of that curve, it's the opposite. Those who received the targeted therapy were doing better than those who received the immunotherapy. And they did take a look at those patients, and there was 24 patients who had early deaths on the immunotherapy, and their median overall survival was only about 3 months. They tended to be patients who had kind of a worse performance status, likely in part due to worse overall disease burden. They had high LDH, they were more advanced stages. The reason patients came off treatment, 39% because they progressed, 26% because they died, and none of those patients were able to cross over to receive the targeted therapy. So trying to identify which patients that you're going to start on immunotherapy might fall into that group, I think, is important, because they may be the ones you want to put on BRAF/MEK first, kind of make sure they don't progress, try to get them to immunotherapy. But that's still unknown at this point. But the bottom line is that immunotherapy is the preferred frontline agent. Now, as a lot of you may know, there was a new approval for melanoma recently, so-called anti-LAG-3 antibody, relatlimab. This is another immune checkpoint, LAG-3. I won't go over a lot of detail of this. Dr. Davis, who's going to talk later on pharmacy updates in cancer, is going to go over the LAG-3 data in more detail. But essentially, there was a clinical trial published in New England Journal of Medicine earlier this year, randomized patients to either single-agent PD-1 nivolumab alone or nivolumab LAG-3. And if you look at progression-free survival, median progression-free survival was 10 months for this new combination compared to 4.6 months for the single-agent PD-1. And based on these data, this combination is now approved. Just look at toxicities across the trials of CheckMate 067 and this LAG-3 study. If you look at grade 3-4 adverse events, it was about 19% of patients in the PD-1 LAG-3 combination had grade 3-4 adverse events, compared to about 10% in the single-agent PD-1. And just to refresh our memory in terms of grade 3-4 adverse events from Ipi-Nivo, it's about 60% of patients had those. So the Nivo LAG-3 seems slightly more toxic than PD-1 by itself, but better tolerated than the older combination of Ipi-Nivo. Now, where do these fit? Our bias is that for patients who are otherwise able to tolerate Ipi-Nivo, that would still be the standard first line. If you're more towards giving them less of a therapy because of comorbidities or something, I think that's where the LAG-3 combination probably fit in. It's probably not, it's going to be select patients where they'd get single-agent PD-1 at this point. So is that it? No, there's more. And I feel I put this slide up for the fellows a while ago, and I don't think any of them knew that this was my cousin Vinny. That just makes me feel old. So felt so bad. But yeah, how could there possibly be more? And we don't have time to go into this, but for stage 3 melanoma, this is melanoma metastatic to the regional lymph nodes. And for quite some time, there's been adjuvant therapy options now, both targeted therapy against BRAF/MEK as well as adjuvant PD-1. That's an option for these patients, but really what's new is that for high-risk stage 2 melanoma, so these are deeper primary melanomas, but no evidence of lymph node involvement, and then obviously no evidence of a systemic metastatic disease. There was a study published earlier this year that looked at PD-1 adjuvantly versus placebo, and there was a benefit in progression-free survival for PD-1 for high-risk stage 2, so this was approved, I think, late last year for high-risk stage 2. And then for uveal melanoma, which is cancer of the pigment cells of the uveal or the choroid of our eye. It's a rare type of melanoma, but very difficult to treat. Previously, no approved therapy, and now we have an agent called tebentafusp, which was approved earlier this year, which is a novel immunotherapy that kind of brings the T cell into proximity of the melanoma cell. And Dr. Davis is going to talk about this, but we also have a treatment option for uveal melanoma at this point, which has been very exciting. So where has all this led for melanoma? Well, what it's led to is improvement in survival for the first time in the history of this disease. And this is 2-year age-adjusted survival for melanoma. And that bottom blue line on this graph is patients with distant metastasis. And it goes back to 2001, but you could go left on that curve all the way back to ancient times, and that survival's never changed. We didn't have a therapy that improved outcome for these patients up until about 2010, when these targeted therapies and immunotherapies came into practice, and you can see that survival is improving steadily since that time, which is very exciting. And even though melanoma is increasing in both males and females, and it's leading the way in terms of incidence in males, and second in females. If you look down at the bottom in terms of cancer deaths, it's decreasing both in females and males. So it's rising incidence, but improved survival for this disease, which is exciting. So just to wrap up here, just to throw a little bit in about non-melanoma skin cancers or keratinocyte carcinomas specifically. There's both basal cell carcinomas and cutaneous squamous cell carcinomas. And these are the most common, not just skin cancers worldwide, the most common cancers worldwide. and they're predominantly associated with exposure to UV radiation. So it's the mutagenic effects of UV radiation that leads to these tumors, and there's just a high number of cases. Now, fortunately, most of them are localized, easily managed, but there's such a large number of them, even if it's a small percentage that become locally advanced or metastatic, it still results in a relatively large number of patients needing some effective therapy. And these are patients who have come into our clinic, this one on the left with locally advanced cutaneous squamous cell carcinoma, this patient on the right with locally advanced basal cell carcinoma. You know, these are hard to treat. And for cutaneous squamous cell carcinoma, it was just maybe 2 years ago we have our first approved agent. We didn't have anything approved for this, but there was a so-called EMPOWER study that took patients with advanced cutaneous squamous cell carcinoma, either metastatic or locally advanced, and they were treated with cemiplimab, which is a PD-1 antibody. And it showed a response rate, objective response rate of about 50% in these patients. And here's some representative patients. The top guy with multiple scalp nodules with a marked reduction in his tumor burden, an ulcerated posterior auricular mass, much improved. And the median time to response, which is in that box, is about 2 months. So you often see these tumors respond very, very quickly. And this is the patient that came into our clinic. We treated him with PD-1 antibody, and he had a complete response to therapy, and he's done well for many years now. And we also have data now just published recently, presented recently, for locally advanced and metastatic basal cell carcinoma. And this was published in Lancet Oncology, an overall response rate of about 31% for patients with advanced basal cell carcinoma. Now, these are previously treated patients because we do have a targeted hedgehog inhibitor, which I won't go over. But in terms of disease control, about 80% of those patients. So these tumors can respond to immunotherapy as well. And interestingly, the time to response to basal cell carcinoma is not as rapid as squamous cell carcinoma. Median time to response is about 4 months. So you need to treat these patients a little bit longer to see benefit, but you still can see dramatic benefit. And these are some of the patients that were on that clinical study, patient with previously treated tumor infiltrating his ear with essentially complete response, and one on the forehead. So again, immunotherapy to treat non-melanoma skin cancer is approved. So just to wrap it up, melanoma and non-melanoma skin cancers continue to be major contributors to morbidity and mortality in the US and worldwide. And modern therapies, particularly immunotherapy, has led to improved survival for patients with advanced melanoma for really the first time in history. But also importantly, immunotherapy has demonstrated high response rates and durabilities in other skin cancers, Merkel cell cancer, which we didn't talk about, but squamous cell cancer is the first approved agent, and metastatic basal cell carcinoma and locally advanced basal cell carcinoma as well. Thank you, and I will end it there.